Welcome to Focus on Health, a series of educational programs highlighting current health issues sponsored by the Department of Nursing at Salisbury University. I'm Dr. Mary DiBartolo, Professor of Nursing at Salisbury University and host of the program. I welcome back Caroline Mansy to the program.
Good morning, Mary.
You've been on before talking about this very important topic of diabetes, and of course it's ever-changing. So we thought it was time to get back together and do an update on this, particularly in terms of type 2 and the medications. And there's many medications that are currently being used. Before we get to that, I just want to mention you are a nurse practitioner. You are board certified in advanced diabetes management. And I believe that makes you a diabetes expert.
I think so on most days.
Well, I appreciate you coming in.
Thank you for having me.
And I think the first thing we'll do is let's first start with an overview of diabetes and the types.
Okay, well basically we have, I think everyone knows we have two different types of diabetes, and they're totally two different diseases. We have type 1 diabetics who are totally insulin deficient, and this is caused by an antibody. And classically everybody feels like type 1 diabetes used to be called juvenile diabetes. They were diagnosed when they were much younger, and that's kind of the way we always thought of it. But over the past, several years, we've actually seen a kind of an influx of patients in the adult world getting diagnosed with type 1 diabetes. So basically, any of us could have this antibody in our system, and for whatever reason, when it gets triggered, or if it never gets triggered, we won't get the type 1 diabetes. But when it gets triggered, that's what causes this type 1 diabetes, and it totally wipes out the beta cells in the pancreas that makes the insulin. So therefore, the patients need insulin both when they eat and a long-acting insulin, because we need insulin to be able to live.
Not just during digestion or when you eat.
Right, because we're constantly producing stored glucose and our sugar, and so we need insulin to live, and without insulin people will not live. So these type 1 diabetics, it's a lot of work for them. They have to take multiple injections a day. The pills that you see advertised on TV won't work for our type 1 diabetics, and so it's a very much more complex, time consuming type of disease.
And it does oftentimes start younger, so people can have more problematic complications down the road.
Correct. Is the long-term effects of it, because it does a lot of times start as young as in infancy, but it also can occur in people in older age, 60s, 70s, 80s. It's how the body reacts. They believe sometimes to different stress issues, whether it be an illness or emotional stress, that sometimes can trigger that antibody to create this destruction of the beta cells in the pancreas.
Now, what percentage of diabetics have the type 1?
About 10% have type 1 diabetes. The other 90%, which is the more common, is the type 2 diabetes. And so we know that risk factors for type 2 diabetes, not only is it genetic, but it's also lifestyle, being overweight, inactive, a very sedentary lifestyle. Diet has a lot to do with it. And so that's what we we really like to focus on in the beginning with our type 2 diabetics.
Now, is it true that it's more prevalent in the U.S., partly because of our Western diet? You mentioned diet, the types of foods we eat here, fast foods and so forth.
Yeah, and I think, this is kind of one theory out there. Over time, over evolution, when we didn't have, cars and different types of transportation, and, farmers really had to, work hard, and they didn't have, motorized vehicles and stuff, we were much more active, so we could eat a lot more food because our body actually needed it. Over evolution and over time, obviously we've become much more sedentary, even in very active jobs. And so this has created almost an epidemic of obesity that has created also this type 2 diabetes epidemic.
And some would argue with the food industry, and portion control and just an emphasis on sugary drinks and things has also complicated things.
Absolutely. When you go out to eat and you get a meal that could probably really last you for 3 meals, our food industry has done this, a lot of it, because of we think we're getting more bang for our buck just when we get more food. or we never feel like we're getting our money's worth if we go to a buffet. And so these kind of things are what a mindset that people have to like say, nope, we need to back up and we don't need this much food.
Well, that's another show.
Yes.
But what we'll get to now is, I know you wanted to talk about the pathophysiology, or why or how. What are all the factors involved? It's not just a matter of the cells, the beta cells in the pancreas not putting out enough insulin. That's a big part of it, but you said there's many other organs involved and processes in the body involved in this.
That's correct. And so the other thing, so there's something called the ominous octet, and that's 8 core defects of what causes high blood sugars in our type 2 diabetics. And basically, yes, it is the first day that a patient is diagnosed with diabetes, on an average, they've already used up about 80% of their insulin. So even if they're doing everything right, they have less and less beta cells, which produce the insulin in the pancreas. That, in turn, the pancreas also has alpha cells. Those alpha cells produce glucagon, which stimulate the liver to spit out more glucose. We know our type 2 diabetics actually produce more of these, produce more glucagon that stimulates more glucose production from the liver, which raises the blood sugar. And then on top of that, we have what's called insulin resistance. So we know that fat tissue releases free fatty acids. Those free fatty acids, in turn, it cause the insulin resistance at a muscular level, which means insulin resistance means that the patient has enough insulin out there, they just can't use it properly. And then we have what's called a decreased incretin effect in the gut for our diabetics. And basically what that means is that they have a low level of a circulating hormone called a glucagon-like peptide. And basically what that glucagon-like peptide does is it suppresses the hunger, it slows down the stomach from emptying, it makes it so people can actually utilize their insulin better, and it suppresses the liver from spitting out stored glucose with the alpha cells from the pancreas. So when our diabetic patients have a low level of this, they actually can't utilize their insulin properly that they have in their system. They get hungry more frequently, and they don't get as full as fast. And so you take all of these things together, and their mechanism of action works different than a non-diabetic. Then there's something called a neurotransmitter dysfunction in the brain, and basically what that is that's insulin resistance in the brain cells. So that's why our diabetics are more hungry than non-diabetics, because their brain cells are resistant to the insulin. And then we also know that our diabetics, there's a class of drugs called, our diabetics reabsorb more glucose than non-diabetics. So someone who's not diabetic, they're going to start spilling sugar when their blood sugar reaches a lower level, versus a diabetic. If their blood sugar goes up, they will not spill sugar until their blood sugar is over 220. And so they're reabsorbing, which makes their blood sugar go up.
So that's the kidneys involved there.
Correct. And yes, so it's reabsorbed from the kidneys. And lastly, the liver spits out more stored glucose in diabetics than non-diabetics. And a lot of times that's why patients get up and they say, why is my fasting blood sugar first thing in the morning so high? Because I haven't eaten all night, and that's their liver's production of that glucose overnight.
So this sounds like 8 different mechanisms, why they call it the octet, involving several different organs. So no wonder, this is much more of a complex disease than we thought. Mm-hmm. It's not just about the pancreas.
Correct.
So that's interesting. Now, how is this diagnosed? Are there like levels of severity? Right. And we've also heard the term prediabetes. So elaborate on that.
So here's what we know. We know that sometimes we kind of miss the boat as healthcare providers in diagnosing our patients and treating them early on. A prediabetic is someone that's blood sugars are not high enough to be classified as diabetic, where they may have a fasting blood sugar first thing in the morning, whether it be on lab work or someone pricks their finger for a blood sugar, between 101 and 126. A diagnosis of a diabetic is a fasting blood sugar over 126, or a random one during the middle of the day greater than 200. Now, if we talk about lab work that we do for our patients, we can diagnose our patients with what's called a hemoglobin A1C. And basically what the hemoglobin A1C is it's a 3-month average of how the sugars have run over the past 3 months. I always like to say, it measures the amount of glaze on the outside of your donuts. So what it does is it looks at our red blood cells, which are reproduced once every 3 months, and it looks at the amount of glucose that can't be transported inside those red blood cells because of either insulin resistance or there's not enough insulin in their system to transport that in there. And we all have a little bit. So a normal hemoglobin A1C is 4.2 to 5.6. A prediabetic is 5.6 to 6.4, and anything over 6.4 is considered type 2 diabetic. And the American Diabetes Association, their goal for an A1C is to have the A1C less than 7. And that's been done through studies to prevent long-term complications, both heart disease, stroke, kidney problems, losing your eyesight, what they call diabetic peripheral neuropathy, which is the numbness and tingling in the hands and feet. So diabetes is a disease that can affect all your organs in your body. So it's very, very important that we do take whatever measures it is to get that in best control as possible without causing side effects from that.
It's a huge risk factor for renal failure.
Yes, it is, and especially here on the Eastern Shore, that's extremely, extremely bad, higher than a lot of the other parts of the country.
Right. Now, before we get into the treatment, which is essentially insulin medications and so forth, what are some of the basic signs and symptoms people would experience that should cause concern or have them call their primary care provider?
So high blood sugars, symptoms are being really thirsty all the time. If you're drinking, all of a sudden you're drinking all this water or more soda or just more any type of liquid and you're drinking more, your sugar could be high. Urinating more, having to get up at night more frequently than you used to. Blurred vision. You can't really concentrate. You kind of feel like your head's in a fog. Abnormal weight loss without really trying. That really means that that's not a healthy way of weight loss. It means you're not metabolizing your food and everything's just kind of going right through you and you're not able to use it correctly.
So we'll move on to treatment.
Okay.
Now we know there's no cure, and now I understand why with the octet system you just described. It's just not a single thing. But of course, we're seeing more and more medications and classes. I'd like you to give present that analogy we discussed before the program, that it's similar to hypertension in a way because there's different mechanisms.
Right. The way, over the years we've always treated high blood pressure with different types of medicines that would hit different aspects of that high blood pressure. Well, now we kind of do the same thing with our type 2 diabetics. So, we've seen a lot of commercials on TV of new diabetic medications. It seems to me like every other commercial almost is about a new treatment for our diabetics. So, what we do, all these new medications actually target these core defects. A lot of the old ones do too, but we have a lot of new ones that never targeted some of these core defects, and we only had the old ones to stick to. So let's look at first, we know there's a decline of beta cells, and the beta cells in the pancreas produce the insulin. So we know we have insulin, and we can always use insulin to help convert that foods inside the cells. We also know that there's an old class of drugs called sulfonylureas, and that's medications like your glipizide, your glimepiride, those different medicines. And what they do is they actually stimulate the pancreas to spit out more insulin from the beta cells. There's also another
But that's why they don't work in type 1. Because
Correct.
there has to be some function of the beta cells.
There has to be some insulin, beta cell function in the body in order for these medications to work. You're absolutely right. Then we have metformin. Now, metformin's main mechanism of action is suppressing the liver from spitting out stored glucose. And metformin is a very, very good drug, old drug, cheap, and it's usually the first-line therapy. And and the ADA recommends that we get people started on metformin early on, while their A1C, if we've caught it early, is still below 7. And because if there's no contraindications, because we know that starting a medication early on in diabetes can help delay adding an additional medication.
And what does metformin target again?
It suppresses the liver from spitting out stored glucose. And the important thing to remember is, yes, every time you see your healthcare provider, you need lifestyle modification. You need to continue to work on that. And that's so, so important.
That's the first step, isn't it?
Absolutely.
Talking to the patient about lifestyle.
Weight loss, diet, and increase in your activity. Then we have the next class of older drugs is called TZDs. And there's really only one of those back out on the market right now. It's called pioglitazone. And basically what pioglitazone does is it helps with decreasing the insulin resistance at the cellular level. So that's really a great drug because it makes the cells actually utilize the insulin that you still have in your system better. But patients who've had a history of any type of congestive heart failure cannot use this medication. That is the big contraindication of that one.
And people would know that as Actos.
Actos,
yes. See that advertised.
Yes, Mary. And so some of the newer medications classes is the first one is the DPP-4, which you might know that as Januvia. And basically what a DPP-4 does, DPP-4 is an enzyme that is in our system that actually blocks another hormone, the glucagon-like peptide, that in the incretin effect that we spoke of earlier, that diabetics have a low level of. So when DPP-4 blocks this at the normal level, whatever level of this other hormone the diabetic has, it cannot get across that barrier in order to utilize the insulin and slow down the stomach from emptying and everything that a GLP-1 would do with someone with a normal level of a glucagon-like peptide. So that's the main mechanism of action. It helps to work on the incretin effect. Then the other incretin effect medication is a glucagon-like peptide receptor agonist, and you might know this as Bydureon or Victoza or Trulicity. Those are the three ones out on the market. And they are an injection, but they are not insulin. And how they work is on this incretin effect. So these are replacing that low level of that glucagon-like peptide, of that low level of hormone that type 2 diabetics have. So when you think about what that hormone does for a non-diabetic, when we give someone a pharmacological level of this medication, they won't get as hungry as frequently. Their stomach will, they'll get fuller faster because their stomach that slows down the GI system. They will be able to utilize their insulin better, and it also suppresses the liver from spitting out stored glucose. So it's hitting directly about 4 out of those 8 core defects. Indirectly, it hits about 6 out of 8. So it's a really good one medication for a bang for its buck. There again, you're hitting a lot of those core defects. But it is an injection, but it is not insulin.
Now, how often do they take that injection?
Some of them are once a day, and some of them are once a week. And its biggest side effect is sometimes some nausea. And there again, if you watch your portion sizes when you start this, and you listen to those fullness cues that we get in our brain, and stop when you feel the fullness come on, the nausea will be less.
All righty. There's another class, correct?
Correct. There is the SGLT2s, which these are the ones that you see about that they spill the sugar into the urine. So we just talked about the kidneys reabsorbing too much sugar from the urine in diabetics. So this is a pill, and it's a once-a-day pill. And some of the medications are Jardiance, Farxiga, or Invokana in this class. And what it does is it lowers the blood sugar by spilling the sugar into the urine. If you remember correctly, I said a diabetic does not start to spill sugar into their urine until their blood sugar reaches a threshold of about 220. Well, this medication actually lowers that threshold down to about 40 or 50, and when they reach that point, they'll start spilling sugar into their urine. So,
better there than in the bloodstream.
Yes. So
yeah.
it's a very good drug. But there again, you've got to watch kidney functions, and they have to emphasize that you always have to drink a lot of water with this medication. So you need to keep very well hydrated. It has a little bit of a diuretic effect, and I believe those are the main classes of drugs. And that's kind of the way that we look at treating our diabetics with these new medications.
Now, is there a usual sequence of these things? You mentioned you usually start with metformin these days. And do you add drugs as you go based on what mechanisms, are
But I feel
in action right at
so
the time?
The American Diabetes Association always every year puts out a new algorithm of how we should treat our diabetic patients. And first-line therapy is metformin and lifestyle changes, unless metformin is contraindicated. And then it's one of the other agents. And then after that, basically it says that we can add anything we want to metformin, any of these medications we talked to about, including insulin. And, we really just need to focus on, we need to do whatever it takes to get our patients at goal, and we're going to treat the patient. So if I have a patient that comes in that maybe has a lot of long-term illnesses, chronic diseases, I'm probably not going to make their goal for their A1C quite as low as what I would do with a healthier patient that doesn't have a lot of chronic illnesses, because I don't want to raise that risk of hypoglycemia or low blood sugars, which goes along with a lot of these medications. But the newer medications notoriously don't cause hypoglycemia, but as we know, the sulfonylureas, which is the glipizide, the glimepiride, those medications do cause low blood sugars. Also, insulin causes low blood sugars, but the other ones do not unless they're used in combination with these other medications.
Well, you mentioned the key is control, yet you have to worry about long-term implications of diabetes and the short-term,
right,
with the blood sugar going out of whack each day, and of course they're monitoring their finger sticks and so on. But you have so many more weapons now, it seems.
Oh, absolutely. And the other thing I'd like to emphasize is the importance of sticking your finger and checking a blood sugar, at least once a day if you're in really good control, twice a day if you're on a basal insulin or a long-acting insulin. I always tell my patients, the more blood sugars you bring to me, the better I can treat you. And it's very important to be very knowledgeable about your disease process, that you can be proactive. And I feel like if my patients understand what's going on with their disease, they're going to be a little bit more apt to maybe go home and realize that they have to make some changes in their life.
Now, similar to hypertension, since you have so many classes to choose from, you can try different things, right? If something doesn't work or has untoward side effects, just like with blood pressure medicines,
correct,
you can try something else.
Correct. And I always say that you're right. And I look at the core defects, and that's where I target my patients. So if they come in and their hemoglobin A1C and their blood sugars are not where we've established that goal should be, and let's say they're just on metformin. Well, I know metformin's main mechanism of action is to suppress the liver from spitting out stored glucose. So then I look at the patient, how much overweight are they? What is their activity level? What is their willingness to change? All these things kind of go into the factor. And what's their A1C now? Are we almost to goal, or is it really high? Are their blood sugars running really high? We may need a stronger medication if their blood sugars are running really high, because if we add one of the medications that's not real strong, we're still not going to get the effect that we want from that one medication. So it does get complicated, and you should look at the whole patient and say, this is where we need to go with this medication, and this is why we need to go here. And there, again, if you're having a side effect from a medication, you can't stay on it, whether it be anything from nausea or diarrhea, or you just can't stay on it. We have enough tools in our box to be able to switch into something differently for our type 2s, which is the beauty. If there's anything good about being a diabetic these days, is we do have a lot more tools and therapies that we can use to target our diabetics today.
Absolutely. It's just so exciting, and I imagine there's more drugs in the pipeline being developed in the absence of a cure. So what would be some really important take-home points you'd like to emphasize? I know what I've gleaned is it's definitely about control on your end, and you have numbers and algorithms and standards, but it gets down to the patient too, being compliant with the recommendations.
Correct. I mean, I always, if your healthcare provider gives you a plan and you don't feel like you can do it, you need to let them know. But it's real important to remember that just decreasing your portion sizes of food, not necessarily changing your whole diet. It's just, making those portion sizes smaller, having one starch with a meal instead of bread and pasta, just having a little bit of the pasta, not a whole plate. It's the little changes, trying to cut out regular sodas and sweet tea, or a lot of juices or Gatorade out of your diet. Those things are the little things, and make those goals little and achievable. So it may be that, if a patient's drinking 4 regular sodas a day, I'll say, can you cut it back to 3 this time? And in 3 weeks, cut it back to 2. Make those goals little, because when the patient sees progress, they're willing to make those changes. On the other side of this is activity. I don't particularly always use the word exercise. I'm increasing a patient's steps. I don't care if it's getting up from the chair once an hour and just standing up. If that's something they haven't been doing for a while, that's increasing their activity. But making those steps progressive and going a little bit further and further, and making those goals a little bit more every day and every week.
Right, make it achievable, small steps to achieve the
Correct.
overall goal. I mean, for diabetes, I know it's one of those diseases where you have to make so many different lifestyle changes in various areas and take medications as prescribed and check the blood sugar. So it's a tough disease in that regard. But if you make it more manageable to the patient, that they can achieve those goals, I imagine it goes a long way.
That's very correct, Mary. It is. It's a very difficult disease to go home because it's always there in front of you. It's not like taking your blood pressure medicine or your cholesterol medicine. It's always there. Every time you sit down to eat, it's there.
Well, I imagine there's plenty of information our viewers can get elsewhere. I know we'll post some websites at the end of the program. And again, I thank you so much for coming on the program to enlighten us as to all these new developments with medications, because it's very important steps towards really getting a handle on diabetes.
Absolutely. Thank you so much for having me, Mary.
And thank you for joining us for this edition of Focus on Health here on PAC 14.